Hi, a very good afternoon to all, and thank you for joining us for this webinar. I'm Dr. Cheryl Low, Head of Department of Psychological Medicine here at Changi General Hospital, Singapore. I believe we have with us here today people from across the healthcare professions. And while most of us are in Singapore and it's 4 o'clock in the afternoon now, we are also joined today by our guest speakers and delegates working in healthcare in the United Kingdom. Hello. It's probably about 8 a.m. for you now, and I hope you had a good coffee. Although it isn't standard treatment for delirium, it does do wonders for alertness and concentration. Last year, this time, in the thick of the COVID pandemic, we held this Delirium Day webinar. We didn't talk about COVID, which was probably quite a nice attention-shifting task. We talked about delirium in epilepsy and with anticholinergic drugs. We heard how electronic data collection can help delirium care. There were perspectives from geriatrics, psychiatry, inpatient nursing, and family caregiving. As we crawl away from COVID, we can say that pandemics come and go, mental states fluctuate, but delirium will always be with us. This year, I am sure everyone will benefit from the 4 presentations we have lined up from our guest speakers. And then the Singaporeans will join in, and we hope there will be a lively and challenging Q&A panel thereafter. I do hope that what you discover with us today will be the seed that pushes better care for patients, that is as inventive and polymorphic as the condition itself. I'm sure knowledge in healthcare is not only for cure and survival statistics. So together with that, let us also look forward to care that comes from understanding and is heartfelt. That is truly what brings us together today. And now, to start off the webinar proper, I'd like to invite Associate Professor Augustine T, Deputy Chairman Medical Board, Changi General Hospital, to give the opening address. Augustine, please.
Thank you, Cheryl. Okay, good afternoon to colleagues in Singapore, and a very good morning to our friends in the UK, as well as globally all around the world. I'm very pleased to be here today to welcome you and deliver this opening address. World Delirium Day is celebrated worldwide in March, and here in Changi General Hospital, we continue to raise awareness on delirium. Such efforts serve to enhance care for our patients and their caregivers. This delirium webinar today is an excellent platform to advance our learning as healthcare professionals in an area which is demanding both in terms of clinical service and care needs. There is still much more to understand in the science behind the array of symptoms that we see in our patients with delirium. The theme for World Delirium Day 2022 in CGH is innovation in clinical services. We firmly believe that it is inadequate to treat delirium as a long string of individual symptoms by us jumping into action when each one appears. It is a challenge facing our most vulnerable patients. It is a fast evolving disorder, placing healthcare providers at increased stress when handling delirium episodes. And it is a complex condition. The solution for one symptom can be the precipitant for another. We cannot act as individual healers in this. We need to work as a team for our patients using preventative steps, early detection, and accurate analysis to design a holistic treatment plan. To this end, we are delighted to have with us today international partners from the Perioperative Medicine for Older People, POPS, an innovative service at Guy's and St Thomas NHS Foundation Trust in London, UK. Our thanks for speaking to us today. We look forward to hearing from your experience in managing the many facets of care in older people, going for a surgical operation, which is a situation that's increasingly common nowadays as our population ages, and one where delirium commonly arises. On that note, I would like to thank the organizing committee and welcome all delegates from Singapore and globally. Thank you very much for being here with us and wishing everyone a fruitful learning session.
Okay, I'll start. Thank you, Cheryl and Dr. T. I'm very pleased to welcome you all. Many thanks for tuning in into this international event. I'm very honored to introduce you all to the POPs team, a fabulous team at GSTT. I'm going to begin introducing our first speaker, Jugdeep Dhesi. Jugdeep is a lead for the innovative and award-winning POPs service. She is the honorary reader at King's College London, an associate professor at UCL, with research interest including pre-operative assessment and optimization, health services research focusing on perioperative pathways and post-operative delirium. Jugdeep is extensively involved in medical education, has co-authored e-learning modules, MSc modules, and multiple textbook chapters. She's a Deputy Director for Center for Perioperative Care, Vice President Clinical Quality BGS, and is involved in a variety of steering, advisory, and guideline groups, such as BGS and NICE, to list a few. And from my personal experience, a fabulous geriatrician. Over to Jugdeep, please. Thank you.
Oh, thank you so much, Bharathi, Dr. T and Dr. Tan, and thank you for the invitation to come and speak to your group today. So I'm just going to start sharing my screen and seeing if that works. So here we go. Let's open up there and hopefully, there we go. So hopefully, Bharathi, you can see that, and if you can't, then let me know, but hopefully that's all clear. So although the focus today is very much on on delirium per se, what we thought we'd talk about this morning is about the real issue of delirium within our surgical settings. And I'll explain kind of why we think that that's so important in the next 20 minutes or so to set the scene for the rest of the multidisciplinary team who will be talking about some of the initiatives that we've taken to address delirium in the surgical setting. Whenever we're starting these talks, I think we should always start by recognizing the fact that with the successes in health and social care, we're seeing our population living longer and living healthier. But of course, we also know that age comes with age-related problems, and half of the years lived beyond the age of 60 are associated with health-related issues. And of course, this isn't surprising because we know that there is physiological decline with aging, even in the fit older patient. We know that multimorbidity increases with aging. So the populations that we see across our hospitals are more likely to be presenting with at least 3 coexisting conditions. We also know that geriatric syndromes such as frailty increase with aging. And so really with that kind of background, we're not surprised to see patients like this lady, a 78-year-old lady, living alone without very much social support, been labelled as being a difficult historian, having some osteoarthritis for which the orthopedic surgeons have seen her and said not for surgery, diabetes and hypertension, which is suboptimally controlled but not terrible, some shortness of breath, which has been investigated by the primary care practitioner and put down to probably related to aging, and now presents with some borderline anemia, and then is found to have maybe a bladder cancer or a gynecological issue or a colorectal issue, and is planned for an elective procedure. And what happens when patients like this come in for their procedures or present to us in healthcare? Well, first of all, patients may decline surgery because we've not been able to communicate the information in a way that has made sense to that individual. It may be affected by their own underlying health literacy. And she may say, well, I'm in my 70s, I'm going to die soon anyway. I don't think I want to go through with this. Or she may have seen somebody else who's had a stoma, for example, and not want to have that same burden from the intervention. Or she may get picked up as having these medical issues and be identified as having anemia and diabetes and shortness of breath, and then referred off for medical opinions. But who do you refer to? Sending her to the hematologist, the diabetologist, the cardiologist, multiple appointments, which often end up delaying what's going to need to be done in the perioperative setting. Or she may come in on the day of surgery, and we know that lots of patients like this lady get cancelled on the day of surgery, not having followed the instructions clearly, or there then being raised a concern about her medical status by the anaesthetic team. But of course, patients like this do proceed with surgery as well, and they often proceed on our amazing enhanced recovery programs, which have been established across different surgical settings, but very much focus on the immediate perioperative issues, the immediate preoperative issues like counselling and carbohydrate loading, exactly what surgical and anaesthetic techniques need to be undertaken, and then what needs to happen in the first 24 hours after surgery. She may actually also have access to a prehab program, which often address things like smoking and alcohol, exercise and nutrition, and counselling. And she may go on to level 2 care, but then come back to the ward. And this is where we see these kinds of scenarios often unfolding. So we know that patients who have uncontrolled pain preoperatively are more likely to require higher doses of opiates postoperatively. In a gut already affected by small vessel disease from diabetes and hypertension, and then with the added insult of the cystectomy and the opiates, not surprising that she develops an ileus. Being put onto intravenous insulin, getting a little bit dry, therefore developing an AKI. Then we end up giving her some fluids. The fluids dilute down the anemia. She's more anemic, we give her blood. She then develops peripheral edema. And so then we think we better give her some diuretics. And through this episode, starting to present with features of delirium, whether that's hypoactive and hyperactive that we'll hear more about from Jude shortly. And of course, that's when we the surgical teams often think, well, the patient's being a bit apathetic. Maybe they need a little bit of a boost. Let's give them some antidepressants. And every day being tied down to different tubes, drips, not being able to mobilize, the delirium, the distress related to that, again, that we'll hear about later, resulting in a functional decline such that she isn't as able as she was before she came in for her surgery, and now requires rehabilitation or a care package to be able to go home with. And of course, we see this across our surgical settings, and we've seen this across nations in all of the data that comes out from Singapore, Australia, UK, US, that actually these are the same issues globally. And therefore not surprising that older people with that pathophysiological profile are at higher risk of adverse outcome, whichever one of these measures we look at. And of course, they're at high risk of delirium because of these types of issues, because of the predisposing and precipitating factors that we'll hear more about from Jude shortly. And of course, this is a massive issue for all of us everywhere, particularly because we know that twice as many older people have surgery compared to younger, and this is across all surgical subspecialties. And this is even more of an issue now with COVID and the impact that that's had on both elective and emergency surgical services. So what do we do about this? And that's what we're going to hopefully be illustrating through this morning's talks, is how we address delirium within this other complexity that presents with our patients in the surgical setting. So often I think we can get caught up thinking about just the complexity of the patient and sometimes about the pathway, but these are the other kinds of things that we've been thinking about through the POP service to try to improve outcomes for all of our older surgical patients. And I'll go through some of these in the next few minutes. So when we're thinking about addressing this complex patient who's at high risk of adverse postoperative outcome, we need to think about all of these things, the physiological issues and multimorbidity, the frailty, but then also things like disability, cachexia, sarcopenia, all the things that predispose people to having issues such as delirium. And if we're going to think about that in a logical way, then we need to think about how we screen for those predisposing factors, how we assess and optimize, how we then plan the patient's care and deliver it through a hands-on approach. All of this being underpinned by shared decision-making. And often, kind of certainly to the geriatricians in the audience, when you start to see that kind of process illustrated there, this makes us think of comprehensive geriatric assessment, which provides us with an underpinning methodology to be able to address those multi-domain issues using multidisciplinary interventions, which often have at the heart of them what is now increasingly called prehabilitation. But of course, that's been part of CGA for many years. So we know we have a very good evidence base for CGA in a variety of settings, medical, inpatient and community settings, illustrating how it's a very effective intervention. And it's that intervention that we've used here at Guy's and St Thomas's, kind of always sunny, but certainly is today here. And so we've used CGA as the underpinning principle for our POPS model, so perioperative medicine for older people undergoing surgery. And this is a schematic of how the service runs. And I'll go through it in a little bit of detail, but not too much in the next few minutes or so. So patients are referred to us preoperatively on the basis of surgical complexity, multimorbidity, frailty, or cognitive issues. And then they're seen in a preoperative clinic, a one-stop clinic, where we have a focus on assessing and optimizing across those multiple domains. We then follow the patient through onto the surgical ward, and there we also pick up the emergency admissions and manage those patients in exactly the same way. So what kinds of interventions does CGA prompt in the surgical setting? And this is some data for the 500 patients who've just been through our service, illustrating how lots of different interventions are prompted by CGA. Lots of new diagnoses, things have gone missed by previous consultations, or that patients haven't approached healthcare services to address those issues. Lots of medicines management, so 3/4 having medicines management. But I've also put into bold there the things that would normally also be delivered through prehabilitation programs. But you can see how there's a whole lot more above the prehabilitation programs. And a lot of communication with patients and a lot of shared decision making. And so if we go back to our lady, then these are the kinds of things that we might do for her. Making sure that we've assessed and treated her pain appropriately, recognizing that we're not going to be able to suddenly control her diabetes and her blood pressure so much better in time for surgery, but that we can plan for that better. Diagnosing things like underlying diastolic heart failure in somebody with diabetes and hypertension, treating the iron preoperatively, but also with this label of difficult historian, diagnosing that she does have cognitive impairment and starting to think about what we can do to address consent in the context of that, prevent delirium, and then manage delirium. And Bav and Jason will be discussing how we do that. And then post-operatively managing, well, first of all, identifying those post-operative complications early with a proactive approach, and then managing them proactively, but also according to the evidence base that Jude will discuss. So this service is delivered across our elective patients. So we see around about 1,600 elective patients and follow them through the pathway, but we actually pick up far more patients through the emergency pathways as well. So that's kind of great because you can say, okay, well, it kind of makes common sense and we can see why that might work, but is there any evidence for this kind of approach? Well, I think it's always important to have local evidence, and we can see here in this table how each year we've put in a new business plan to gradually grow the service to what it is today. But we've also been doing pre and post studies, quality improvement work, an RCT, systematic reviews, illustrating how these kinds of approaches can effectively improve post-operative outcomes for older patients. And this is now being supported through big data studies. So we have data coming from the National Emergency Laparotomy Audit, showing how geriatric medicine input is associated with lower mortality rates. And we've also seen nice data from the initial 4 years of NELA, seeing how the biggest improvements in outcomes, whether we're looking at mortality or at length of stay, have occurred predominantly in the older population. And there's an increasing evidence base for this kind of approach. But interestingly, there's of course always negative studies as well. And it's really important to acknowledge and recognize those studies. And when we look at the negative studies, one of the consistent features that comes out is the fact that most of these studies weren't delivering CGA according to its core principles. So really important that if we're going to use CGA, we show fidelity to the underlying process. So again, that's fine because a lot of that work has, of course, come from one centre, but how do we then start to ensure that we can translate this across healthcare systems? Certainly back in 2014, we knew that only 3 centres were delivering this kind of approach, and lots of people said, well, we'd love to do this, but we can't because we don't have the workforce and we don't have the money to do this. And so this was a bit of a challenge back to us. And so these are the kinds of things that we've been doing to try to upskill and support the upskilling of the workforce, from our allied health professionals through to the foundation year doctors year 1 and 2 after medical school, the specialist registrar years, but then also the national and international approaches that we've been developing through e-learning modules, MSCs and conferences. And both Bav and Jason will touch on some of these aspects through their talks, but of course we're very happy to discuss those in more detail as required. So that's the workforce, but what about the money? So to address this, we've been developing business plans to support the setup of such services and sharing those business plans with other centres who are establishing perioperative services for older people. But we've also, Jude has published her health economics analysis of the RCT of CGA in vascular surgery, showing that this is a cost-effective approach. And what's been really exciting is then seeing how there's been an increase in the number of services being set up across the UK. And actually, it's also increased again since 2019. And the way that we've been trying to support now that scale up and roll out of these types of services through this kind of approach to knowledge mobilization has been working with an organization called NHS Elect, an arm of NHS England here in the UK, where we've developed a toolkit to support the rollout of the services. So all of our clinical resources, education and training, the business end of things, put that together into a website, but then supporting that with coaching and mentoring for those units who are setting up and providing support with measurement for improvement. And we're just on our second cohort of centres now taking part in that. And what we're hoping is that each of those centres now, the early adopters, become the regional centres and then gradually roll out across their areas to ensure that this happens at the speed at which it's required. So do take part. If you're interested, then drop us an email. And that really brings us around to probably one of the most challenging issues around traditional attitudes and behaviours. We've very much often thought about surgical patients and medical patients, and there's been a real kind of lots of silo working. So to address this, of course, we need to have joint working, and that's really come out through a number of reports that we've been working together with a variety of different groups on to make sure that we're thinking about this as a whole. And that's really why the Centre for Perioperative Care was established, a collaboration between all of the different associations and colleges who contribute to the perioperative pathway. And we were really pleased to be publishing our guidelines on perioperative care for people living with frailty last year, which we really hope will support the implementation of the services that are necessary. So in those last few minutes, I hope I've given you a little bit of a feel as to how we can improve outcomes for older people having surgery. And of course, delirium sits at the heart of this, being the most common post-operative complication that we see in our older patients. But we can't just focus in on one condition. We do need to think about this as a whole, and this requires this multimodal approach that I've just described. There's some resources which I'm sure Bharati will then circulate to everybody, so we'll be pleased to hear from you. But I'm going to stop at that point and then hand over to the next speaker. Thank you.
Thank you, Jugdeep. So that was a breathtaking presentation and delivered with such clarity as always. Great to see you today. So several takeaways. Please pop in your questions using the Q&A function and do stay tuned in for the next session. I'm very honored to introduce you all to Jude Partridge. Jude works as a consultant geriatrician within the POPS service at GSTT. She leads the POPS vascular service. Jude is an honorary senior lecturer at King's College, London, and research interests are in health services research, delirium, and frailty in the perioperative setting. And again, in terms of my personal experience with the entire team, a very inspiring team, Jude is a fabulous and dynamic geriatrician. Over to Jude, please. Thank you.
Thanks very much, Bharati, and the organising committee for inviting me to join you in this session today. I'll just share my screen. As a slideshow.
Yes.
That's working as a slideshow.
Yes, it is. Thank you, Jude.
Excellent. Okay. So good afternoon, everyone in Singapore, and thank you very much. As we've heard from Jugdeep, of course, the issue of delirium is something that most of us encounter on a daily basis. And it's no surprise that we see it so regularly because, of course, we know, and we've heard already, that our older surgical population is aging. And we know that with age, not only comes the surgical problems that patients present with, but also multimorbidity, or the accumulation of 2 or more multimorbid conditions, but also physiological age-related changes. So things such as cardiac physiological deterioration, respiratory deterioration, but of course relevant to delirium, also cerebral vulnerability. And we know that the older brain has structural changes, different function of neurotransmitter systems, and also changes in the blood-brain barrier, all of which make it vulnerable. But it's not just the structural changes, but also the prevalence of conditions such as dementia, which of course this population increasingly exhibit. And increasingly in perioperative settings, we're also seeing that kind of burden of undiagnosed cognitive problems. So this has been shown in elective orthopedic patients by Liz Everett's work, but we've also looked at this locally at Guy's and St Thomas's in a vascular surgical population, where we've shown through brief cognitive assessment tools at presentation for vascular surgery that actually 2/3 of patients have abnormal MOCA scores, and that the majority of these did not have a diagnosis of a cognitive problem. So there may well also be a burden of undiagnosed disease in this population. And of course, these brain changes, this prevalence of dementia, and this burden of undiagnosed disease make the older patient very vulnerable when they present with a surgical pathology that needs an operation, so the controlled trauma of surgery under anesthesia, which is a very excitotoxic or neurotoxic type event. And this is shown here by the cytokine responses to this controlled trauma of surgery in a vulnerable brain. And of course, this can lead to various perioperative cognitive disorders, the most common of which and the most widely studied, which is delirium. And this audience will be well familiar with the commonly described predisposing and precipitating factors for delirium, which we see on this slide. And it's worth just remembering these and holding them in our mind when we look at the literature to prevent delirium, because of course, much of it is trying to target these things. So just to remind ourselves what we mean by delirium, of course, we know that this is defined by the DSM-5 criteria, and you see the definition there. But it's worth just remembering that in the surgical or perioperative setting, just as in our general medical settings, there are different types of delirium. So there, of course, is hyperactive, hypoactive, and mixed and subsyndromal delirium, just as we would see in the medical setting. And then also the timing of delirium, which is described slightly differently sometimes in the anesthetic literature. So normally we would talk about prevalent or incident delirium, and that's how the British NICE guidelines define it. But in the anesthetic literature, there's of course emergence delirium, where a patient wakes from their anesthetic in a delirious state, most commonly actually a pediatric phenomenon. But then interval or postoperative delirium after recovery from anesthetic is the same as we would call our normal postoperative delirium. And although I know this is going to be touched on later by my colleagues, of course, we must remember that there are significant consequences of delirium. And that's not just in the traditionally reported mortality and morbidity, but also in terms of other things such as process measures. So a longer length of stay in hospital, institutionalization greater in those patients who have suffered from delirium, with of course economic implications, coupled with the emerging literature that we have on the distress related delirium that I know Bav will be touching on a bit later. So given these significant consequences of delirium, what does the literature say about whether we can prevent this condition? And broadly speaking, the literature in prevention of perioperative delirium falls into two camps: multi-component interventions to prevent delirium, and then trials looking at medicines to prevent delirium. And the majority of this work is nicely summarized in this Cochrane review from a few years ago, which looks at these things. And then I'll just touch on depth of anesthesia monitoring as well, which has just snuck its way into the Cochrane review as well. So let's just remind ourselves what we mean by these multi-component interventions. And of course, the first multi-component intervention in the literature was described back in 1999 by Sharon Anui's group. And what they did is, remembering those predisposing and precipitating factors for delirium, was they employed a multi-component intervention to target the precipitants for delirium. So really simple things administered by nursing staff or nursing carers to reorientate patients, to prevent dehydration, to ensure a normal day-night wake-sleep cycle. And what they found in a medical group of patients at risk, so older patients, was that there was a good adherence to this multi-component intervention, and that it was effective in reducing the incidence of delirium. Very shortly afterwards, Mark Antonio's group translated this to the at-risk hip fracture population, again with good adherence to the multi-component intervention by the orthopedic teams, and again showing a reduction in incidence of delirium in the group that received this multi-component intervention in comparison with standard care. Those studies were quite a long time ago now, but we've seen increasing work published recently, again, showing that those multi-component interventions remain effective. So this was a more recent paper in non-cardiac surgery, looking at, again, a HELP type multi-component model, reducing delirium effectively, and actually, interestingly, involving the family in doing some of those simple tasks, making sure patients were awake and engaged in the day, that they were getting regular drinks of water, that they were regularly reorientated. So a nice model of care which families wanted to be involved in. And then published more recently, again in January, this is a multi-component intervention trying to prevent hospital-acquired complications, which actually was not effective in achieving its primary outcome, but very strongly reduced delirium incidence again. So papers still being published with fidelity to Sharon Anui's original multi-component model, showing that this is an effective way for us to reduce delirium in an at-risk surgical population. So what about medicines? Because of course it would be much easier if we could just write up a medicine to give a patient before an operation that would reduce their chance of getting delirium with all of the consequences we've discussed. Well, over the years, there have been various agents studied, all of which have a reasonable biological basis why they might work. So of course, haloperidol and similar drugs in that class. Melatonin has been studied in both medical and surgical populations, dexmedetomidine in intensive care studies, and then smaller studies looking at medicines such as donepezil, and quite a lot of work in the surgical population looking at whether damping down the pro-inflammatory state associated with delirium using steroids can be effective. And although there are odd studies showing that some of these agents, so one study showing that methylpred may be effective, some data from intensive care showing that dexmedetomidine may be effective in non-cardiac surgical patients. Overall, when you meta-analyze these studies, there isn't yet a convincing drug that can be given to reduce the incidence of delirium. So some promising work and certainly lots of ongoing work, but at the moment, the Cochrane review, when it meta-analyzes this data, tells us that drugs don't work in the prevention of delirium incidence. That doesn't mean that we don't look at the drug charts of our patients with delirium, though, because of course we know that avoiding certain medicines commonly used in the perioperative setting is really important in preventing delirium. So we must remember benzodiazepines that have a significant increase in causing delirium. Although used much less frequently than other opioid medicines, those opioids that have anticholinergic effects as well should be avoided in patients at risk of delirium. And then the opioids versus pain discussion, which commonly comes up both clinically and at conferences. And of course, we know that whilst opioids can trigger delirium and are quite a potent trigger for delirium, so of course is pain. And so using opioids in as much of a sparing fashion as we can, but ensuring that our patients do not have post-operative pain is really important. And I think increasingly we're seeing a better use of kind of adjuncts to the intravenous use of opioids through things such as nerve blocks. So for example, fascia-iliaca blocks in hip fracture, using nerve blocks for patients with critical limb ischemia or after amputation, and using nerve blocks for patients presenting following trauma with rib fractures, all of which can often minimize the amount of overall opioid which is used, but keep the patient pain-free, avoiding pain as a delirium trigger. So multi-component interventions do work. Avoiding certain medicines works in preventing delirium, but we don't yet have a prophylactic drug we can give to prevent the incidence of delirium. I mentioned depth of anesthesia monitoring or BIS monitoring earlier. So there is some evidence which came out in the Cochrane review for using this depth of anesthesia monitoring, which is done through EEG monitoring in theatre. And it was endorsed by the Cochrane review, but there are quite a lot of concerns raised when these studies are discussed about how accurate BIS is, both clinically and in terms of the study data, and whether actually there was quite a lot of heterogeneity between the patients included in this study and meta-analysed, and whether we will be able to translate generalisable results from it. So some suggestion, which also sounds sensible, of course, with face validity, that monitoring depth of anaesthesia may reduce the incidence of delirium, but there's still ongoing work to make sure that this is kind of conclusive. So it snuck its way into the Cochrane, but it isn't yet completely conclusive. So this little diagram just aims to try and summarize what I've said here, showing those things that have got a strong evidence base in the literature to reduce post-operative delirium, and those things which don't yet have a strong evidence base, but which of course studies are ongoing to examine. But I think just finally, as Jugdeep mentioned earlier, it's really important that although we've looked at this literature and we know what it shows, we have to remember the implementation gap that exists, particularly when we're talking about these complex multi-component interventions. And as Jugdeep has touched on, we don't want to spend a lot of time and effort embedding a multi-component intervention for delirium alone, ignoring the other medical problems that we know older, frailer surgical patients also run into in hospital. And rather, we should be incorporating these multi-component delirium preventions into comprehensive geriatric assessment and optimization in order to improve outcomes across the board for older surgical patients. And so we've heard, of course, that CGA is both clinically and cost effective. And we see very much from the CGA literature that whilst it improves length of stay and it reduces medical complications, consistently one of those medical complications is delirium. So we can address the implementation gap between the literature to prevent delirium and what we do in our day-to-day clinical services by employing CGA in the perioperative setting for older, frailer surgical patients. So in summary, what does the literature say about whether we can prevent delirium? The multi-component interventions work, but must be implemented as part of CGA. We don't yet have a drug treatment that we can reliably give to prevent delirium, but work is ongoing. This monitoring may have a role, and we should be ensuring our patients are pain-free at the time of surgery and avoiding certain medicines. So a quick whip through the delirium literature. Very happy to take questions at the end on those things I didn't have time to go into. So things such as POCD and delirium distress that I know my colleagues will be touching on later. Thank you very much.
Thank you, Jude. It was such a comprehensive academic update. Great to see you today. So do stay tuned for the next session, and please pop in your questions into the Q&A using the Q&A function. So I'm very pleased to introduce you all to Jason. So Jason's career has focused on surgical patients. He's worked within trauma and orthopedics and joined GSTT in 2002 in the orthopedic pre-admission clinic. Jason was one of the leading practitioners involved in developing and implementing the nurse-led orthopedic pre-assessment service. This model of care is now used in the Trust Central pre-operative assessment clinics. He joined the POPs team in 2008 and divides his time between outpatient clinics and the wards. He works in the one-stop shop nurse-led clinic for colorectal patients, and on the wards, he liaises with the surgical teams providing specialist nursing and medical advice for patients over the age of 65. A very inspiring nurse clinician, Jason. I'm very, very pleased to invite you. Thank you. Over to Jason, please. Thank you.
Thank you very much for the fantastic introduction. I apologize. I will bring it all back to COVID because I'm in my son's bedroom with COVID at the moment. So apologies if I convulse into fits of coughing, but it's a pleasure, and I thank the committee for inviting me to speak. Good morning in sunny London, good afternoon wherever you are. I'm going to share my screen with Zoom, which is not I'm not particularly au fait with, but I think you should be able to see my screen. I should be able to start that. Here we go. Are we ready to go? Can everybody see that? So yeah, I'm Jason. I'm a nurse specialist. Been at Guy's and St Thomas's many years, and at the moment I'm actually working at a different trust, doing some setup of POPs, leading a project there. And so delirium is really quite high on my list of priorities at the moment, and how we integrate that within the education within the nursing teams at Lewisham and Greenwich, where I'm working at the moment. And we've already heard from Jude and Jugdeep regarding kind of the literature behind delirium. But what's really important, I think, when you're thinking about shop floor, thinking about nursing, thinking about patients at the beds, staff at the bedside, obviously this proactive identification of patients who are at risk of delirium is really important. And I'm always saying, and I say it pretty much daily, acting is better than reacting. And I've become a bit of a mantra for me. But I do believe that probably the best way forward with managing patients with risk is by utilising our current workforce, recognising that generally it's the staff at the bedside who have the expertise, who often notice those slight changes in patients' condition. But what they obviously need is support with upskilling to recognise those changes often escalate into a full-blown delirium. So providing them with knowledge, and this helps engagement, with the wider team. So by optimizing knowledge and then recognizing those early stages of delirium, you're engaging with the wider team, you're escalating those issues earlier. But also, you're embedding a recognition of the wider impact of delirium. And I know that Bav will talk about delirium distress, and we talk about the distress of delirium to patients, but also we need to recognize the distress not only to relatives who see their patients who are delirious, but also to the staff, who, if they haven't got that underpinning knowledge and understanding, really do find it quite distressing. It's the patient who's kicking off and hitting out, but also the patient who's withdrawn and not accepting treatment. You know, that can be distressing not only to the patient, as I say, but also to the relatives and the staff themselves. And to understand what that looks like at Guy's and St Thomas's and the other centres that now are embedding POPs, one way we've looked to address that upskilling is by having a nurse specialist. And at Guy's and St Thomas's we use nurses, but other centres use other allied health professionals such as occupational therapists, physiotherapists, and they act as a focal point within a surgical specialty. So we have a nurse that's attached to a surgical specialty or ward. I myself work within GI surgery at Queen Elizabeth Hospital, Woolwich, and that provides a continuity of care. But also there needs to be some flexibility. So that nurse specialist or that specialist is there for early morning handovers. And I'm not just talking about surgical handover, but I'm talking about nursing handover as well. So they're there first thing in the morning at nursing handover, not waiting to be asked to see a patient who may be deteriorating, actually looking and spending time with the nurses to understand what their patients have been like for the past 24 hours. Now, I'm guilty of this. And it's a big bugbear of mine. I want to stamp out the whole kind of theory that patients are pleasantly confused. And how many times have we seen on a nursing handover, you know, that patient is pleasantly confused? Because we know delirium isn't pleasant. It is distressing. It will cause problems, you know, increased length of stay. Jude touched on the kind of morbidity and mortality impact of delirium. So it's my mission to stamp out the pleasantly confused. And I'm proud to say that my work within the GI unit at Guy's and St Thomas's and some of the early work I'm doing at Woolwich, we're not seeing that now in nursing handover. And that's because we are visible and we're useful. And I'm a great fan of liaison teams, liaison services. I think they have a great way in sharing expertise, but there's nothing better and nothing more effective than that, actually having a specialist embedded within a ward team, somebody who is visible, who is useful, because they provide the ad hoc and structured teaching that's needed to upskill our nursing and ward teams. But that needs to be backed up with simple advice and simple tools to highlight those patients who are at risk of delirium. And this has become even more important recently with the advent of electronic notes, which have really taken the nuance out of admission assessments. You know, a lot of them are very much tick box exercises. So we need to be informing our nurses or providing our ward teams with simple triggers that will maybe highlight those patients are at risk. And sometimes it's just very, you know, there's simple questions. Have you noticed any change in your memory? You know, what operation are you having? That maybe ring those early alarm bells. Sometimes a little bit more in-depth questioning is needed. You know, who manages your household bills? And then if they say, well, I can't do that anymore, my husband or my son now does that, that should then be triggering the nurse or the ward team to recognize that maybe there are some issues that need to be addressed. Now, if you're thinking somebody's got cognitive impairment, then obviously we should be doing a MOCA and an MMSE, Montreal Cognitive Assessment Screen, or a multi MMSE. I won't got out there top of my head. But what we have been suggesting is the 4AT. And that is a simple assessment that we use that can be used for delirium, highlighting delirium and cognitive impairment. And the 4AT is simple, 4 questions, looking at alertness, recall, some attention to detail with some asking somebody to repeat some months backwards, but also then asking whether there's been a change in cognition as well. And what we've done, both at Guy's and St Thomas's and where I'm working currently, is we've integrated that to the standard admission assessments. So it's a question now that it is asked, so 480 is asked as part of the assessment when the patient hits the ward. It's completed by a member of the ward team. And also we're looking to integrate it into our daily board rounds, so hand rounds, our daily kind of board discharge rounds, when we're looking at those patients who have just come in, trying to highlight potential issues as they progress along their surgical journey. But if somebody develops delirium, what can you do? And luckily, there's a wealth of guidance out there. There's the plethora of guidance. But if I'm honest, I find a lot of it's not particularly user-friendly. Local translation, I know some of the guys in St Thomas's guidance is great, but again, isn't particularly user-friendly, but there's nothing stopping you designing your own. And this is great because it engages the staff in the process of developing something new, but also embeds knowledge within the whole process. So not only are they designing something that's going to help patient care, but they're learning about the issue as well at the same time. And this is something that was done at Guy's and St Thomas's with staff engagement led by one of our consultant geriatricians called the Delirium 5 project. It was a redesign of patient and staff information. So it was just one set of information for both. It incorporated a new assessment for delirium into our electronic system, so the confusion assessment method, but also provided educational support for the staff during the design process. And these were some of the information that was produced. As I said, the new confusion assessment method was embedded into our electronic system. So taking it away, making it easy, it was flagged on the electronic system as an admission screen, easy to access. But then there were the 5 aspects of delirium: talking to the family, preventing falls and doing. So there was guidance around each aspect of the 5. And I'll go back a slide here. You can see them here. 5 actions within the first 5 hours. And I think this is a fantastic example of staff engaging in a project. As I said, embedding knowledge in the staff, but also produce that with an output that then benefits patients, relatives, and staff. I'll talk a little bit, give you a little bit of a case example around how some of these interventions influenced a patient's care. So this gentleman, known to the surgical team with an enlarged prostate, had been having recurrent urinary infections, as we see with patients with BPH, and he was on the list for a transurethral resection of prostate to help relieve his symptoms. He had pretty benign past medical history, hypertension, CKD, and high cholesterol, as documented on his medical notes and his local care record. But he was admitted from clinic. His wife had kind of expressed concern that he was becoming aggressive. He seemed to not be taking his medications, in particular his blood pressure medications, but also his medications for his prostate. He had disturbed sleep. He was unsteady on his feet, and she was having to monitor him really closely because he had a few near misses with regard to falls. And on review of his admission bloods, he had a good going AKI. He had a urinary tract infection, and using the 480 on admission, the nursing staff had highlighted that he had a delirium. Excuse me, sorry. So ward review, he was diagnosed with urinary retention with some outflow obstruction and a UTI, and he was wandering on the ward. He was delirious, and the surgical team had put a very specific plan in. They thought we should be doing the TURP as soon as possible to relieve his symptoms. He was going to have a catheter. We're going to give him some IV fluids and IV antibiotics and repeat his bloods in the surgical plan. But as you can expect, delirium was hindering his intervention. He was sitting out. He didn't agree to his blood tests, and so we had to intervene. And luckily, having a nurse specialist, geriatrician available on the ward at the time, we were involved in the process right from the beginning. So relatively promptly, We highlighted obviously he lacked capacity. He was declining treatment. He wasn't aware of his the risks associated with declining treatment. We applied for a deprivation after a best interest meeting. We applied for a deprivation of liberty safeguard, a DOLS, so we could provide him the treatment that he needed, even if he was declining. But underpinning all of this was what Jude was talking about, were those simple interventions that were led by the nursing team and the ward care team throughout his stay. So the hospital elder life program. So those simple interventions, ensuring he was hydrated, encouraging him to drink, reorientating, keeping, trying to maintain his day-night cycle. So keeping him awake during the day. And that's, I suppose, one of the overarching things about delirium management is that there are many precipitants there, and it is very complicated. But often the simplest interventions are the cheapest, and they're the easiest to apply. So we have designed a rounding form, so an hourly rounding form for patients with delirium, attached to a behavioural chart which helps describe their delirium as well. So every hour, the ward team, it doesn't need to be a registered member of staff, it could be family, it could be a healthcare worker, to orientate that patient every hour, give them a drink, keeping them awake, asking if they're comfortable, assisting them to the toilet. Those really simple interventions, and they really benefited this chap. He did initially require some sedation, but only for a very short period. Because of the best interest decision and the DOLS, we chose the less restrictive option. So you had the IV antibiotics and the IV fluids. Sorry, not IV fluids, oral fluids, just to help rehydrate. It took longer for his AKI to resolve, but it was the least restrictive option. And his delirium did settle within 3 days. It was supported by his family on the ward, so he relaxed visiting times, and they helped with a lot of the rounding and the help style interventions. We removed the DOLS after about a week, and he went home with his catheter, and he came back at a later stage to have his TURP. We highlighted that he had a delirium risk, and he did have some delirium post-operatively. That was managed very brief, with a very brief period of for treatment intervention. But he went home within normal time. So I didn't do a summary slide, and I'm kicking myself now because, but I'm very happy to talk. But one thing I did want to finish with, and I've got no idea if I've talked under or over. I'm sorry, I have no clock, and my brain's all a bit foggy. But I really encourage everybody, to look at the educational resources around delirium that are out there. So there's the British Geriatric Society Delirium Hub for healthcare professionals, allied health professionals. There's international rates. I think it's an absolute bargain for allied nurses and AHPs, £42 a year for access to that. And there's also within that, there's the POPs, special interest group e-learning module you can access for free as well with membership. Within our own bespoke POPs, excuse me, education module, there is delirium included within that. We've trialed that as a 2-day course online, and we're going to be running that again. That looks at CGA, a whole breadth of of condition management, as I said, including delirium. I'm hoping to run that again in the middle of this year. That's been delayed slightly because I'm off doing other work, but one of my colleagues will hopefully be taking the lead on that. And then coming soon, kind of building on the initial work we've already done at Guy's and St Thomas's, I'll be working with Health Education England around an advanced clinical practitioner credential in perioperative care, which will look at delirium, capacity, cognitive impairment as one of its core modules. And that is also informing an application to one of our local universities to design a master's diploma or postgraduate certificate in perioperative care, and that again will focus on delirium in perioperative management as well. So that's me. I think I've done all right. Sorry for the coughing. I'm happy to answer questions at the end of this, but thank you again. Cheers.
Thank you, Jason. A very speedy recovery to you and your family. Thank you so much. I can't thank you enough. You need to take some rest. So it's been a very inspiring and enriching session. A key takeaway, embedding an integrated model involving nursing, staff nursing specialists in terms of a liaison model of care. So that's been very enriching. So please stay tuned for the next session. Bhavini is our next speaker. I just wanted to double check any problems logging in. Bhavini, you're there. So Dr. Bhavini Shah works as a senior clinical fellow with the POPs team. She's interested in surgical liaison services and medical education. It's always wonderful listening to clinical fellows, trainees. Trainees continue to inspire us in so many ways. Thank you very much, Bhavini. Over to you.
Great. Thank you very much. And thank you for the committee for inviting me to speak today. I'm really excited to tell you about my experiences, and I'll just share my slides if you just give me a second. Great. So my talk today is talking about how we can upskill our junior surgical doctors in the prevention and management of delirium. Now, we know that this is difficult. It has been difficult in the past and it remains to be difficult. It's traditionally seen as a problem for physicians, but even amongst physicians, it's seen as a problem for geriatricians to deal with. However, as we have heard, it is increasingly important that all medical professionals are trained in delirium. As we have heard, it is very important because it's common. So by 2025, more than 1 million people in the UK will have dementia, and the number of older adults having surgery is increasing. Delirium is far common than other complications seen in the surgical population. For example, fatal PE or even a surgical wound infection. And we know that delirium has significant consequences on morbidity, so things as falls and pressure areas. We know that delirium increases short and long-term mortality. It has a significant effect on the financial cost, so the length of stay of a patient with delirium can be increased fourfold. And of course, this includes emotional impact. So patients have significant psychological and psychiatric sequelae. We know that delirium is under-recognized. And why is it under-recognized, knowing that it is so common? Well, from the literature, we know that there are deficiencies in provider knowledge. And a survey undertaken in 2006 of UK junior doctors who were not in specialist training showed poor knowledge of diagnostic criteria and the treatment of delirium. This survey was repeated after a set of national initiatives and guidelines, which increased the prominence of delirium. And the survey showed that although there was improvements in some aspects of delirium knowledge, the diagnostic criteria for delirium remained poorly understood. Upskilling our surgical colleagues about delirium is vital. It is very important to reiterate and remember that surgical colleagues are not any different to any other juniors. They can be upskilled in the prevention and management of delirium, and delirium is something that the surgical team can and should be enthused about. So how do we go about doing this? Well, we know that the junior surgical team will be tomorrow's surgical consultants, and they will have responsibilities for patients. We have seen what delirium can do to surgical outcomes, and so this should be incentive for the surgical team to become upskilled. All surgical teams should know how to screen, diagnose, and complete basics of management. We know that the traditional post-operative complications, such as DVT, PE, wound infection, and hemorrhage, they're looked out for by the surgical team, and now delirium should be part of this list. So in order for the surgical team to start thinking about delirium, to be able to start managing it, they need to have an increased awareness of it. So we know, for example, by things like the World Delirium Awareness Day, that we are now having national and international initiatives to increase the awareness of delirium. Education and training is the key to this. So in your local areas, you can organise teaching sessions by the local geriatric team. There is lots of online learning about delirium. So for example, on the British Geriatric Society, there is a delirium hub, which has a vast range of information and resources for anyone to use. And what about surgical training interviews? We know that in the UK, the surgical training interviews have one station, which is a clinical scenario station. And in recent years, they've had this clinical scenario station as post-operative delirium. And this enforces the juniors who are about to undertake these training interviews to read about delirium. So this is an important way of trying to upskill the junior team. We can also use the role of simulation, which I will come on to a bit later and talk about in a bit more detail. And of course, upskilling the entire team, all the allied health professionals, is really important, as Jason has talked about, as we know that upskilling the entire team provides the best possible care for a patient who has delirium. So this is just a screenshot of the BGS Delirium Hub. It contains a wealth of information, from quite basic knowledge about delirium to quite complex situations. And this is accessible to anyone. So we know that simulation is a very valuable tool, and we know that we can increase confidence and knowledge of delirium through the use of simulation. At Taunton and Somerset Foundation Trust, they developed and implemented pop-up delirium simulation training using real-life models. So they used their specialist nurses who were trained in delirium to write some scenarios, and they also played the part of the patient. And their results found that they had a 27% increase of their participants who had had a 27% increase in confidence recognizing delirium, a 33% increase in their knowledge level, and a 23% increase in confidence for caring with the patient with delirium. And similarly, at St. Mary's Hospital in London, the team devised multidisciplinary simulation training on delirium, and they also found something similar. They found that simulation training targeted at multidisciplinary groups is an effective way to deliver teaching on delirium. It contextualizes synergistic operation of different skills and personal accountability in influencing patient management. So how do we turn this into reality? So first, to be able to manage delirium, first the team must be able to identify it. So things we can do to identify delirium, so that nursing staff can screen their patients. Any of the allied health professionals can flag patients that they're worried about. And again, this comes back to the point of how important it is to train the entire team. And of course, we can always identify delirium on ward round. The 4AT, and I know Jason has mentioned this, but it is a simple, quick, and well-validated bedside tool which helps practitioners detect delirium in day-to-day practice. It does not require specialist training, and it is very easy to implement. So again, the 4AT is something that can be used by the entire team. And how about other ways or tools to alert the surgical team? So we can use posters on the walls just to remind the team of the signs and symptoms of delirium, and also to remind them to look out for it. Having ward rounds with the multidisciplinary team allows any member of the team to raise any concerns they have about a patient who is drowsy or agitated or aggressive, and providing patient leaflets for the family so that the family can raise any concerns. And I think this is really important, as they know their family member, they would be able to identify any changes in behavior. I find that lanyard cards as a prompt are really useful. So you can see here that this is a card that we use at Guy's and St. Thomas's Trust. It is a card that has been developed that can be attached to lanyards, which is very easy to access. It just provides a prompt and a reminder for the things to look out for when we're assessing somebody who has delirium. And of course, developing local hospital guidelines. So this is just an example of guidelines that have been developed at Guy's and St. Thomas's. It's on the intranet. It's very easy to access. The whole team can access it. And it's there for people, for any part of the team who want further detail or help in management of delirium. Early involvement of family is key in patients who have delirium, as it helps to reorientate them. And again, more posters. So this is an example of a poster which is called The Usual Suspects. It is just a reminder that there are many drugs that can precipitate and worsen delirium. So things like this, the posters act as good prompts for the entire team. I love the use of mnemonics. So we've got two mnemonics here, two examples. One spells pinch me and the other one is delirium. And they're quite easy to remember. Both of them cover the same sorts of things, again, as a prompt for the team. So things like pain, infection, nutrition, constipation, hydration, medication, the environment, things like respiratory failure, and finally metabolic and myocardial. So it covers a lot just in a few lines. All surgical teams should be able to undertake basics of management of delirium. So this includes things like pain management, constipation, urinary retention. However, I think it is very important to remember that there are some scenarios which will require specialist skills where the surgical team may need to get help. And this is by no means an exhaustive list, but just a few examples. So patients who have prolonged delirium, patients who have delirium which is related to alcohol use, patients who have Parkinson's disease or Lewy body dementia, and respiratory failure, and in particular, patients with hypercapnia. As it's been touched on previously, we know that delirium causes a lot of distress. So this is a quote from a patient who has experienced delirium. All types of weird things were going on in my head. The whole thing was terrifying. I remember speaking to Gloria on the phone to tell her that there was a bomb about to go off. I was firmly convinced that this was going to happen. It was the worst experience of my life. So we know that delirium causes a lot of distress in patients, but actually the literature suggests that the impact may be even greater in relatives or caregivers. Preventative actions such as pre-episode educational information for patients and their families in those that have been identified to be at risk of delirium may reduce this distress and psychological morbidity. And this is just a few examples of patient leaflets. So there are lots of online resources, and you can see here that this leaflet from Health Improvement Scotland is it's on the BGS Delirium Hub, so it's again very easy to access. And you can develop your own patient information leaflet. So this has been one that's been developed at Guy's and St. Thomas's, and this is the one that we use at our trust or patient or for us that we use as a POPs team for patients we have seen in clinic who we've identified as being at risk of delirium. We give them this leaflet to go home and read further. And what about consent? So we know that the General Medical Council in the UK, the guidance is that all potentially adverse outcomes must be discussed without assumption of which outcome a patient may or may not find important. And as delirium is an increasingly well-recognized complication, which has potentially devastating consequences, post-operative delirium must be discussed with the patient and their relatives. Is delirium currently consented for? I thought as I come to the end of my talk, it would be really interesting to get some quotes from the current surgical juniors that I work with. I asked them about delirium, what they thought about delirium and how they would manage it. And these were just a few that I've written down. Very hard, I find it very hard to manage, especially on a night shift. Everyone always tells us to get to the bottom of delirium, but how when the patient is uncooperative? Just give benzos. And I want to know more, as it is really common. So we can see just from these few quotes here that knowledge is patchy. There is a lot of work to be done. And what about my experiences? So I've been doing the fellowship now for 7 months, and I feel like I've been acting as an ambassador for delirium. So I've been teaching and training the whole MDT as I go along. So the nursing staff, the physiotherapists, the occupational therapists when I'm doing board round, encouraging them to use the word delirium rather than using the word confusion. I found that teaching the surgical juniors has been hard, as I would talk to them every day about a delirious patient and what we should and shouldn't be doing. Things like analgesia, constipation. But I found that over the 7 months that actually, if you keep talking about it, you keep teaching and you keep training, they do learn. And actually, I'm finding that the surgical juniors are coming up to me saying, I have a patient who is delirious, can we talk through it? Which has been really encouraging. And of course, my own POPs juniors, every single day, they're learning more and more about delirium. So what about future implications and questions? How do we make sure that all surgical teams are aware and learn about delirium? Should delirium feature in all our curricula? And should delirium feature in exams? What about undergraduate? And how about postgraduate surgical exams? And finally, my conclusions. So we've spoken about delirium for the last 2 hours. We know that it is the most common and important post-operative medical complication that has significantly adverse outcomes. Delirium is everyone's problem. All surgical teams should be upskilled in the prevention and management of delirium, and the use of allied health professionals and the involvement of families is essential. Thank you very much.
Thank you, Bhavini. Thank you very much. Several key messages: trainee ambassador for delirium, ongoing education with the surgical team, very practical suggestions and tips, empowering and educating surgical colleagues, working collaboratively. Thanks very much for highlighting on delirium distress and the work undertaken by Jude and the rest of the POPs team. Thank you very much. It was very enriching and enlightening. Thank you very much.
Thank you.
Thank you. We are now, I can't believe it's 5:30. It's just over 5:30. It's gone very, very quick. I would now like to invite all speakers and 2 panelists, please. So we move on to the Q&A session. I'm going to begin introducing my geriatrician colleague, Ui Chun Hao. He's a senior consultant in the Department of Geriatric Medicine at CGH. He's one of the lead clinicians in the Dementia and Delirium Outreach team. I work with him very closely and with Fuin. So Fuin is an advanced practice nurse specializing in geriatrics. She's very passionate about improving nursing identification and management of patients with delirium, and she's spearheaded several projects. Very happy to have both Chun Hao and Fuin as we move on to the Q&A session. Thank you. Can we have the questions, please? And thank you to the audience delegates for the various questions. We have some very interesting questions. So we'll begin with question 1. So we've been asked, could the second speaker, that's for you, Jude, can Jude share the latest evidence, diagnostic criteria with regards to PO? Can we just go to question 1, please? Post-operative cognitive disorder, post-operative delirium as an approach to managing post-operative cognitive disorder. We'll begin with Jude, and perhaps Jugdeep, you can pick up. Jason, it's purely optional for Jason. I would really like him to rest. I don't want to trouble Jason. It's purely optional. Chun Hao and Fuin, please feel free to chip in. Jason is optional. really would like you to take some rest. Thank you. Over to Jude, please.
I'm fine. I'm made of tough stuff. I'm okay.
All right, shall I start and then we'll see how he fares? So thanks for raising this, because in a short talk it's very difficult to cover this, but I think it is important that we go through it a little bit. So postoperative cognitive dysfunction was first described in 1950, actually, and then kind of got into the anaesthetic literature in the late kind of 80s and 90s. And there's been a lot of discussion over the years about how delirium and postoperative cognitive disorder interface. Are they different illnesses? Are they on a spectrum of illnesses? And Liz Everett, who's a professor of anaesthesia in Australia, has looked at the DSM-5 criteria for this and tried to kind of break down more definitive definitions of the two things, looking really at timelines. So does a patient have a cognitive problem before an operation? As that is a separate condition from developing delirium afterwards, then defining POCD as what happens at 30 days and at 12 months after surgery, which is all very valid, and it's definitely a reasonable thing to do to help us understand the literature. But actually, I think if you look at the original studies of POCD, it's a real example of silo working, in that there was no measurement of delirium in these studies of POCD. So I think we can surmise from that what we may well have been looking at was in fact just delirium. And of course, as some of the other questions that have flashed up on the screen have mentioned, we know that patients often haven't had cognitive problems diagnosed before surgery. We know very little about the cognitive trajectory of patients coming into a surgical procedure. So I imagine what we will see as our understanding of this improves as the years go by is that actually, if we knew what a cognitive trajectory of a patient was, what we're really seeing is just postoperative delirium worsening someone's cognitive trajectory, as opposed to an entirely separate disorder, postoperative cognitive dysfunction, which I think is probably going to just turn out to be delirium worsening someone's pre-existing MCI or dementia. So I hope that kind of answers that a little bit. In terms of the management, there is no different management. We manage patients as if they have delirium, and then we follow them up to see how they're doing and how they're recovering from that. And all of the literature that's looked at the role of anaesthesia in these things has shown that there's no difference between general anaesthesia and regional anaesthesia in all of the systematic reviews looking at these conditions. So I think we should really focus on delirium and just watch this space a bit with the POCD, which is probably just a marker of silo working and our lack of understanding of things across specialties. Jason, do you want to chip in?
Yeah, Jason, if it's all right with you. We're still on question number 1. Jason, if it's all right with you, if not, Jugdeep?
There's probably not very much to add really to what Jude's just described. She's given a really great summary of the literature. I suppose the only thing to add, and the thing that she's probably being a bit modest about, is some of the work that she did describing the prevalence of cognitive disorders in surgical populations, which is so much higher than we recognize normally. So in her vascular population, she found that around about 80% of people had evidence of cognitive impairment, but only around 8 to 10% actually were diagnosed with the cognitive disorder before they presented to surgical services. So I think that just reinforces kind of Jude's answer to that question, is that there's so much unrecognized disease out there, and then we're very surprised when they develop cognitive disorders post-operatively. Yeah, that's the only thing to add to Jude's comment.
Thank you, Jude and Jugdeep. We can move on to the next question. I'll leave it to Jason to chip in as and when. He's been busy typing responses. We've noted that Jason has been typing and responding. Thank you, Jason. So this is a question which came from one of my colleagues. So what were the challenges and key factors of success when developing the POP service? I think it may need another talk from you, from the entire team. Briefly, Jugdeep, do you want to kickstart? We're on number 2.
Yeah, and this is often, this is a common question for us, and it's that, it is a very difficult question to answer. But I think the challenges are kind of, some of the things that I was highlighting in our talk, in that we are looking after patients who present with complexity. We're looking after patients throughout a whole pathway, from the community back out to the community, rather than just thinking about the episode of the intervention per se. So there's those challenges. There are challenges around the fact that we just have been slow off the mark in terms of gathering the relevant evidence to support the care for these complex patients in complex pathways. And then, some of the other challenges, of course, are the huge cultural challenges that come when you're trying to establish new services, change models of care, start to break down some of those silos of working that Jude's alluding to, where geriatricians, surgeons, anaesthetists haven't traditionally worked together, and just starting to look at where each of those professional groups add value, and thinking that through, and developing teams that support a patient through the pathway, as opposed to setting up teams that sit within specialties. And I think that's going to be a real cultural change for us in healthcare, is making services patient-centred as opposed to specialty-centred. There's lots of challenges around education and training and how we deliver that, but hopefully, again, Bav and Jason's talks have illustrated some of the approaches that we've taken to that. I think an underlying issue here is having ownership and responsibility. And I think that's maybe some of the reasons why liaison services don't work quite so well, because you're going in, giving advice, and then not feeling responsible and accountable for the care that's being delivered. And I think that's where the shared care models probably work better than the liaison type models. But like you say, Bharati, that's a kind of, we could title a whole day's talks around that particular question, couldn't we?
Yeah. Thank you, Jugdeep. Jude, would you like to add to what was said?
So not much to it. I suppose the only other thing that's probably been instrumental to us here, and we're now seeing instrumental across the country, is just the real importance of being data driven in what we do, and particularly when you're trying to work across different specialties. There is something about the objectivity of data and constantly presenting that data to people that does show that you are benefiting a patient group, that you're doing is cost effective, and therefore kind of engenders buy-in, even where it may not be there emotionally at the start. So no matter how good the data is, just to collect data and keep presenting it back is really helpful in breaking down those silos, because it's sort of objective. So that's the only thing to add, really.
Yeah. Well, thanks very much for highlighting, Jude, on data. So here in CGH, we're looking at some data, and we will be in touch with you, with the entire team. Thank you. So let's move on to question number 3. Over to Fuin.
Yeah, thank you. Yeah, so here is another question asked by the participants. So they're asking, prior to the COVID pandemic, family members or either the caregivers is encouraged to be with the patients to help to meet some of the patient's needs in terms of carry out multi-components interventions. So during COVID period, so the family or caregiver involvement becomes challenging with the no visitors restrictions in Singapore and many other countries. So so what are the alternative solutions to tackle this? Do you have any insight to this? So we do, as we all know, family and caregivers plays very important role in patient's delivery recovery. So can I invite Jason to answer this question as it's related to family involvement, or else some other speaker can also chip in?
I'm very happy to answer it. I mean, it was really interesting, especially during the periods of lockdown when family weren't allowed into the hospitals, that suddenly a lot of technology became available, so we could do exactly that. So there's the use of iPads, staff using their phones to help patients connect with their families, and that has continued. And I suppose that has also kind of led us to think, I mean, look at how we're talking now. I mean, look at how we're talking now. You know, COVID, the positive aspects of COVID around how we connect has been phenomenal. So we still embrace those technologies that we were forced to during the period, those COVID periods. So we're still using those, you know, kind of telephones, iPads to connect with families. But it's still there's not a real substitute for people physically being there. And so even in hospitals now, we have COVID passports, something called a COVID passport, so we can apply, so relatives can come and visit. If a patient is challenging, has delirium, then they are given special dispensation to attend and provide support. Yeah, I think that answers.
Yeah, thank you, Jason. So yeah, pretty much in CGH here, we also resort to connect and carry out some video calls for the family members to provide some emotional support, but it's very short, in a very short periods of time, just a few minutes. They can't be on the phone and sustain that kind of conversation for long. So there's a limitation there, but we do around with what we have. Yeah, so thank you very much. So the next question is also related to COVID situations. Yeah, so the participant actually wondering if there's any evidence out there, look into the differences in terms of incidence of delirium when the family members are barred from entering the wards during the COVID pandemic periods. So could we have Dr. Jugdeep to address these questions?
Yeah, no, it really has been a challenge, hasn't it? And like Jason says, we've ended up having to rise to the challenge with the resources that we have. But I think we've all found that very difficult and very upsetting, and have tried to influence visiting policies such that we can allow people access, as Jason says, using COVID passports. And I think that does fall to us working within this field to be challenging those kinds of policies, because there's no reason why visitors complying with infection control procedures are any more likely to introduce COVID into the ward than any one of us. So I think we do have to challenge those kinds of visiting policies as long as we approach it in the right way. In terms of people looking at the differences in incidence of delirium over these last couple of years, there have actually been a few studies. And probably a couple of the areas that have been most interesting has been one within emergency medicine. So 6,000 patients that were reviewed just before COVID started and then after COVID in Japan. And in the emergency setting, they found that their incidence of delirium was around 2% before the visiting restrictions, and then rose to around 6% after the visiting restrictions. Now, those are relatively low incidence rates of delirium, so it's hard to interpret without kind of going into it in a lot more detail. But I don't think any of us would be surprised to have seen that kind of increase within those settings for exactly the reasons that we're describing, not only the lack of people coming in to visit, but also, of course, the environments that patients found themselves in, with us presenting with masks and goggles and aprons, and being kind of, the feeling of danger almost that instituted for patients, contributing probably as a precipitating factor for delirium. Interestingly, when they've looked at delirium rates within ITU settings, specifically if you're looking at the visiting policy effect, that's not really had a difference, an impact on delirium rates within ITU settings. But of course, we've seen a lot more delirium with COVID itself. So delirium's been a presenting feature of delirium. So again, a little bit hard to unpick how much of that is related directly to COVID, how much of it is related to visiting policies, how much of it is related to the environments that people found themselves in. But I think, what's been, again, a positive to come out of the COVID pandemic is that delirium has suddenly started to feature in professionals' minds more. because they've seen it more frequently. So intensivists are even more interested in delirium subsequent to COVID, as are anaesthetists, surgeons and physicians. So I think this is an opportunity for us to capitalise on, to say, look, this is a common issue within hospitals, and we do need to think about education and training and how we support the workforce to prevent and manage delirium. As Bav was saying, the ways in which we can now engage with surgical juniors as well to really think about this as an important post-operative complication.
Thank you, Jugdeep. Thanks very much. Let's move on to question number 5. We're doing very well for time. If we can take up one more question. So could you share with us on how we can explore outcomes such as falls as part of POP service or another liaison service provision? Bhavini, Chunhao, please feel free to chip in. Jugdeep, so how would you evaluate, how would the POPs team evaluate and unpick the benefits of the POPs team on outcomes such as falls, readmissions, because it's often multifactorial. There's multiple multi-morbidity. There are so many things going on when an older patient is admitted to a surgical ward. So how would you unpick that the outcomes are attributable to the POPs team and the service that you provide? How would you evaluate that?
Yeah, so I think there's probably a couple of things within this question. I think, first of all, you have to be very clear about what metrics you do want to use when you're evaluating the impact of a service. And so, why would you be picking a particular metric? Is that because you're using it to demonstrate improvements in quality of care, or are you picking something because you want to look at the cost effectiveness of your service and you're wanting to build up a business plan for that service? So I think before you start to kind of think about exactly which outcome, you need to be very clear about what you're trying to show and why you want to do that. So yes, falls may be an indicator of quality of care within that setting. So whenever we're using quality improvement methodology or kind of looking at the use of implementation science within these settings, we always kind of start with some baseline data before we're instituting the service that we are putting in. And then kind of really thinking about using all the variety of different methodologies that exist within QI, so looking at PDSA cycles, but really also making sure that you're tracking the impact of the service over time. So, for example, if we've got falls, you'd want to look at that before you implemented the service, implement it, track using SPC charts, for example, but be very clear about each time point at which you may have put in an intervention, so that you can then start to illustrate kind of what you've done and whether then that's had an impact on that particular outcome. Of course, falls is a really good kind of surrogate marker for quality of care in lots of settings, and particularly its relationship with falls is very, with delirium is very important here. We know that many of our falls in hospital settings are related to delirium. So again, you may want to kind of be thinking about tracking delirium incidence, severity, duration as part of that kind of approach. And Jason may have more to add on this, because of course, this is the kind of approach that we take when we're developing our driver diagrams, when we're setting up new services, such as the one that he's setting up at Lewisham and Woolwich at the moment. So I don't know if you want to add more there, Jason.
Yeah, I think two points from there is the first one, which is slightly to the side, is this is often where the setup of services fail, is they don't describe the problem before the service starts and what they're going to address. So somebody comes into post, with some money that's been squirreled away, and they spend a number of months, establishing something without any direction. And then by the time they actually understand what they're going to do, it's the end of their secondment and they go. and so they fail. And we've seen that throughout the UK. We've kind of specialist nurses who've come in as a specialist who, to improve care without really understanding what they're trying to improve. But coming back to what Jugdeep says, interestingly, I had my NHS Elect meeting this week, which was a measurement meeting. And we talked about the problems with using aggregate data. So looking at something as like average length of stay, and how that doesn't really isn't particularly good data to use. And just following on what Jugdeep was saying, you really need to nail down exactly what you want to measure before you can actually prove something. I don't know. I'm not making myself particularly clear. So I did some very quick data around referrals to the frailty service. So I've started a new service, and unsurprisingly, the referrals to the incumbents, the in-house frailty service, have come down. So we're going to use that, do a bit of a case review of those patients to look at the patients who are reviewed by frailty. At what point in their admission stay did they have a crisis that required a referral to frailty? Whether that be an episode of delirium, whether that be a fall, or whether they were functionally declining, not getting out of bed, and then using that, and tracking that within an SPC chart, then looking at how an impact, our impact on the patient journey and their point of crisis. So yeah, it's really important to just nail down exactly what you want to measure, because you may think that measuring this one thing is going to prove what you want. Often it's not the case. And also you should be asking your colleagues, if you're going into somebody else's service and you want to improve care, you need to get buy-in from them as well. So asking them what's important as well, because you may think, oh, I need to reduce delirium incidents and that's going to improve quality of care. But really that manager of that unit may turn around and say to you, actually, what we really have problems with is, trying to get people out of hospital later. And delirium may may kind of feature within that, but there may be some other processes or other bits and pieces you can influence to help them out as well and get their buy-in. Sorry, that was a lot of words, just jumble of words. I apologize.
That was very coherent, Jason. Thank you very much. Bhavini, thank you, Jason. Bhavini, would you like to add from a trainee fellow perspective?
Hi, thank you. Yes, I think from a junior doctor perspective, I think this is all a big learning curve. So setting up a service is something that, we don't get. It's not something that we get experiencing, and getting involved in quips and things like this, learning kind of the methodology, I'm looking at kind of the data, and also from my point of view, I'm helping kind of Jason set up this service at Lewisham, and I've learned lots from Dr. Dhesi in terms of kind of driver diagrams, looking at the QI data, learning how to start these projects. So from a trainee point of view, there is so much data out there that you need to read and understand before you can really start to think about kind of looking at outcomes, starting new services. So yeah.
Yeah, thank you, Bhavini. Chinha, would you like to add? Because we're working on quality improvement projects here in CGH. So it's great to hear from the POPs team.
Yeah, so thank you. Yeah, I think in CGH, we also have our sort of liaison service, right, together, also multidisciplinary. I think the important points that the previous people already raised are to be very careful about the outcome measures, right? And the importance of outcome measures, yes, but also to kind of nail down and choose the measures carefully.
Yeah. My sincere thanks to all the speakers. We're just going to move on to my closing remarks.
You want to do question 6? Last question?
I think we're bang on in terms of time. Okay. Yeah. So let's move on to the last session. The first slide, please. Yeah. Okay. Just move on to the next slide, please. Okay. So my sincere and heartfelt thanks to all speakers from the POP service. I cannot thank you enough. And I remember when I first contacted Jugdeep, we had a discussion about COVID, and I have to say to the entire team, thank you so much for being so very accommodating. I know how busy you are, accommodating in terms of your response to the emails and the various requests. Thank you very, very much from the entire organizing committee. And to the entire delegates who stayed till the end, thank you very, very much. Thank you for your fascinating, thought-provoking questions to make it a very lively session. And to the panelists who are part of the core organization committee. I'm very grateful to CGH management for all the support thus far. CGH Dementia and Delirium Work Group, Sing Health Duke NUS IT support with the Zoom account. Thank you very much. Next slide, please. Very grateful to Cheryl, whom you have met, HOD Department of Psychological Medicine, my colleagues from Geri Psychiatry Service, Om Pusen, who leads us, and my various colleagues, consultants, resident physicians from the Geri Psych Service, and trainees who keep us motivated and inspired. I'm very grateful to Go Ketson, HOD Department of Geriatric Medicine, CGH Comms, Geraldine and City, Lester from General Services, Samuel from Education. Thank you, a big thank you. Next slide, please. And to the fabulous team who worked very, very hard behind the scenes. Belinda, Senior Secretary from Department of Psychological Medicine, Joan, Zilla, Assistant Manager, Clinical Service, a big thank you, my heartfelt thanks. You've met Chin Hao. Barbara, thank you very much. I hope you're watching and participating. Fuin, again, a big thank you to you, Fuin, Louisa, and Zalia. Louisa, thank you very much. Zalia is on a holiday. We've missed you. So it's been great. It's been a fascinating session, and I feel very privileged to have spent time with the POPs team. And little did I know that on my return, it would be the COVID-19 pandemic. So 2019 was fabulous, and then it's been the pandemic. So I'm very, very pleased to meet you all. So it's work in progress in CGH, so we will be in touch. And please fill in the feedback form, using the feedback to shape further webinars. So we'd really like to hear from you. And a big thank you to all of you. And it's time to say bye. And can the various members from the organizing committee join me in saying bye, and we need your feedback. So Jugdeep, Jude, Jason, and Bhavini, we will be in touch. I will be in touch, and we will carry on discussing this further. It's been a fascinating, enriching session. I've enjoyed every minute of it. I had a great time with your team, and also with the with Professor Stewart's team and the Geri Psychiatry Liaison Service. So it's been very inspiring for me, spending time with both Geri Psychiatry at the Maudsley and the POPs team. And I'm so pleased to have put together this webinar. And thanks to everyone for making this possible. Thank you. Bye-bye.